Hello, my name is Michael Wallace. I'm a professor of medicine at the Mayo Clinic in Jacksonville, Florida, and an author of the recently published paper, Endoscopic Scar Assessment After Colorectal Endoscopic Mucosal Resection Scars. When is biopsy necessary? This was called the ESCAPE trial. The lead author was Dr. Kandel, along with many other authors from around the world who are experts in endoscopic mucosal resection. We know that endoscopic mucosal resection is a very valuable method of removing large polyps, typically those over 2 centimeters. However, adenoma recurrence after colorectal EMR is a key limitation. We know that recurrence rates after piecemeal EMR are upwards of 20%. Obvious recurrent adenomas are managed with high success rate, including repeat EMR or standard polypectomy methods. However, it is unclear how to manage non-obvious recurrence. The current options for management of EMR scars are shown here. If we suspect a scar to be negative with no recurrence, should we biopsy it or not biopsy it? If we suspect it to be positive, should we just biopsy it or treat it with an endoscopic polypectomy? Newer enhanced imaging technologies may refine this approach with more targeted biopsies and better guide proper treatment decisions, such as performing a complete resection if it's truly positive, and not performing one if it's truly negative. Here are 3 different EMR scars. On the left is a recurrent lesion which we can diagnose with high confidence. It has classic features of an adenomatous polyp in the scar. In the middle is an area of uncertainty. There's some polypoid tissue which may represent scar or granulation tissue, and in the right is a normal scar which we can diagnose with high confidence. There's no evidence of residual polypoid tissue or even granulation or inflammation. The aim of the current study was to assess the real-time accuracy of high-definition white light or NBI with or without near focus to detect recurrent adenomas after EMR, and also to assess the level of confidence with these optical diagnoses. We aim to assess the independent accuracy of these 4 imaging modes using offline analysis and to assess the inter-observer agreement. During the actual procedure in real time, we assessed each scar with 4 imaging modalities in this sequence: high-definition white light with near focus, NBI, and NBI with near focus. The observer was asked to score each lesion as positive or negative, and also whether they had high or low confidence in their assessment. The accuracy is shown here. As you can see, the negative predictive value was extremely high, as was the sensitivity. Positive predictive value was somewhat lower, and there was similar accuracy across all imaging modalities. Specifically looking at high confidence cases, the negative predictive value and sensitivity approached 100%. We also did a separate offline image assessment. The reason for this is to eliminate the bias that obviously occurs when assessing each separate imaging modality in real time. For example, if the endoscopist thought it was positive with the white light mode, they would be more likely to assess it as positive with the narrowband imaging mode. In the offline assessment, the images were scrambled and presented in random order so that the endoscopist who assessed these was not aware, or at least was not obviously aware, of the diagnosis using the other modality. Here, obviously, the accuracy was lower than the real-time assessment, likely because they were using a single static image without the benefit of real-time video interpretation. Overall, we did, however, see more separation with the white light being of lower accuracy and the narrowband imaging, particularly narrowband imaging with near focus, having the highest overall accuracy, particularly with sensitivity. What are the implications and practical points from this study? First of all, when assessing a scar from a prior EMR, if one has a high confidence of a positive diagnosis, this is very likely to be a true positive and likely should be resected. In this case, the positive predictive value was almost 87%. If the endoscopist is likewise confident that there is no recurrence, this at 100% negative predictive value, and likely no further action is needed, particularly biopsy. In both low confidence situations, whether it's low confidence positive or low confidence negative, the predictive accuracy was only modest. And in this case, if there's low confidence that there's recurrence, it would likely be beneficial to go ahead and resect this, given the 69 to 70% likelihood that there is residual disease. On the other hand, if there's low confidence that it's a normal or non-recurrent scar, The negative predictive value of this is actually quite poor, only 55.5%. So likely this should either be resected or at least biopsied. In summary, our study shows that using high definition, particularly with narrowband imaging, significantly increases the accuracy of assessing Emr scars. In this case, the negative predictive value is 100%, and thus biopsy is likely unnecessary in this situation. It also provides further guidance as to how to manage high confidence positive cases, as well as where the endoscopist is not confident whether it's positive or negative. Thank you very much.